Okay, all right, we're in. Oh, look, you guys are already joining. So if you haven't been able to watch the recording that I did last week, or that was posted last week, I suggest that you go back and look at that just to review a lot of the urinary renal system, how it works, kind of how it all happens. So this is my very primitive drawing, but we've got a body. We all mostly have 2 kidneys, right? And that all the blood flows through here, and the kidneys pull out different things from your body. What do they pull out? Different electrolytes, toxins, waste products, water, fluids, yeah. And so once they filtered it and decided it's either waste, we don't need it anymore, then it goes down through these things called ureters. If our body decides, no, we actually do need this, we need to keep this fluid, we're a little bit dehydrated, it sends it back into circulation from the kidneys. But if we don't need these things, then they follow down the ureters into the bladder. Everybody has a bladder, male, female, everybody. Then you have your urethra. That's how you empty and pee. So today we're going to talk about different disorders in the system. So I'll kind of refer back to this drawing a little bit from time to time to kind of pinpoint where the issue is taking place. Because a lot of times urinary and renal might be broken up into 2 different systems, but really everything's kind of part of one system, right? But I really think that these 2 systems are so closely connected. We're going to talk about them as a pair, because if one system is affected, it's going to affect the other. The other's affected, it's going to still affect this. So let's move on. Let's start with the Minty. Everybody and the Minty for the most part. Let's see. Oh, I'm on. Okay. So our outcomes today, we're going to talk about issues with urinary tract infections, maybe what causes them, what might we see with people with them, also with kidney stones, what causes them, the treatments, risk factors for cancer of the bladder, risk factors and signs and symptoms of cancer of the kidneys. We're going to talk about ileoconduit or conduit reservoirs. These are really interesting. We're going to talk about diabetic nephropathy, nephrosclerosis, hydronephrosis, glomerulonephrosis. Those are a lot of really big words that sound very similar, right? We're going to break all those down so that we know what each of those are, how they're affecting the kidney as well. We're going to talk about acute kidney injury as well as chronic kidney injury. Those are 2 very different things. Treat them kind of the same, depends. We're going to talk about how do we care for those patients with acute and chronic kidney disease, caring for somebody with a vascular access site, like a dialysis fistula or graft, planning nursing care for dialysis or peritoneal dialysis. So the concepts we're going to cover: elimination, fluid and electrolyte balance, infection, and teaching and learning. So the first thing we're going to talk about is urinary tract infections. So urinary tract infections, this is the area that's affected down here. So most people are fairly familiar with urinary tract infection with either themselves, a loved one, somebody else. So when we talk about the urinary tract in the bladder, this is sterile, right? That's why when you guys do your Foley catheter or straight catheter teaching and skills lab, you have to learn to put on sterile gloves to keep your equipment sterile, because you don't want to introduce any pathogens up into this bladder, because this is sterile. This is all self-contained. Now, when we get to the urethra, the opening to the urethra, that is not sterile, right? That's open out to it's like our skin, right? Like we have like protective microorganisms and things there, but our skin isn't considered sterile. But something goes usually from outside up into this urinary tract, often up into the bladder. It's usually caused by E. coli. why do you think it's caused by E. coli? Like, where did E. coli come from?
Or what?
What's that?
Comes from your butt.
Your, right? But we often find E. coli in stool, right? That's where we often will find that pathogen. So why is E. coli getting into our bladder?
Somebody's wiping.
They're possibly wiping the wrong way. How are we supposed to teach our patients to wipe?
Front to back.
Right? Yeah, the front, anterior to posterior, especially for women because of this issue. What about our patients who are incontinent of stool? Right?
It gets a little.
Yeah, it gets all over the place. So men and women can be potential for E. coli exposure. So risk factors. Why is somebody at higher risk than somebody else of having a UTI?
Somebody that doesn't, hold their urine for a long period of time.
Right, if you're
Every year.
ignoring the urge to void, you know, or if you maybe aren't able to void all the way. Contamination, like we just talked about, somebody is incontinent. Instrumentation, meaning more of somebody who can't empty their bladder all the way, and so they have to self-cap. They have to and so that's constantly kind of introducing potential pathogens. That makes them more at risk of having an infection. Reflex from faulty valves, right? When you pee, you're supposed to kind of just open out, right? And you pee out and then it close. Sometimes you can have reflex and it kind of, you know, it will kind of go out and flush a little bit, will flux back in. Female anatomy, just because it is a lot closer to the anus and to possible contaminants, it makes it a higher risk of having a UTI. Aging changes, as well as somebody who has a genital piercing, right? Why? And at first I looked at that and I was like, oh, that's interesting that they included that, but why would a genital piercing make somebody higher risk of having UTI?
That's nasty.
So using our critical thinking, other than just saying it's
Well,
nasty.
because, I mean, if on a male, Prince Albert goes through the tip of the penis, like it goes through the tip, down through the urethra or the ureter, where it causes more openings and more ways for the bacteria to get in.
Right, so depending on what the piercing is, it could cause actual opening into the ureter or urethra.
Right.
It could also, if it's external to the ureter, urethra, you're just having a reservoir, right? So if you have a piercing, if I pierced my skin here, I would have a little tract underneath where the piercing goes through. That creates a potential reservoir for bacteria to live. Same thing if we have genital piercings, but because of its proximity to contaminants like E. coli and other things, it's a lot more possible that somebody could get a UTI or something like that when they have a genital piercing. Doesn't mean you're going to have to, doesn't mean you're dirty, anything like that. It just means somebody has a genital piercing, they're higher risk of having a UTI.
So is it just for men or is it for women
Both.
as well?
Both. So different types of UTIs. So urethritis. So the urethra itself is inflamed. If you've ever had a UTI, or if you've ever talked to somebody, that often will say it hurts or burns when they're peeing. That's that urethritis. Sorry, I'm having trouble saying that word today. But that's because there's an infection in this urethra. It's swollen usually, it's inflamed, and as you pee, it hurts more. So that's urethritis. You could have an infection that's just the ureter or the urethra. Cystitis, that's where the infection has actually come up into the bladder and you have inflammation of the bladder wall itself. So it's kind of an advancement of the infection, if that makes sense. It might start out as an infection here and then move up actually into the bladder. Then you have pyelonephritis, and that's where you have an infection of the kidney. Oftentimes it follows that same path where it starts in the urethra, moves up into the bladder, it's not treated, and eventually follows up these ureters into the kidney. Now you can have a kidney infection You can have a bladder infection without having like a urethra or a ureter infection or. Urethra? Yes, thank you, urethral infection. But typically it would follow from down to up. Occasionally you can just have somebody who has a kidney infection without a bladder infection, but it's not nearly as common.
Yeah, that's what I was gonna say, but, I was pregnant with all three of my kids. Oh, wow. And they said that because I have too much, like, fluid,
Right.
it was too much for my body.
And got it inflamed and infected. Yeah, yeah, so it's definitely not as common, but can happen that way as well. So, first question. Nurse is collecting data on a patient at the doctor's office that has a fever. Which of these findings would be indicative of a UTI? And then it cut off at select all that apply, so you should be able to select multiple. You could only select one? Okay, whichever one you feel is the most, I suppose. Oh, I forgot to say earlier. I know I said it in my welcome video and such. This is a long class. 4 hours is a long time. If you need to get up and go to the bathroom, make a phone call, get food, please do. You don't have to ask or tell me. I do have some breaks built into the day. We'll probably take more breaks than those listed on here. But just please, we're adult learners, self-manage. I trust you to know your body way better than I do. Okay. Oh. Enter. Okay. So symptoms of UTI. So ammonia smelling urine actually isn't a sign and symptom of a UTI. Now when we talk about foul smelling urine, and I guess that's kind of a little bit of a tricky question because ammonia would be indicative of maybe a liver problem or something else, not necessarily an infection causing it. Amber urine would be a sign that it's not, you might see that along with a UTI, but it's not necessarily a sign of a UTI. What does amber urine tell us? Water. It's dehydration, right? A lot of times patients might be dehydrated with a UTI, but yellow colored urine is not necessarily, or amber colored urine is not necessarily from a UTI. If we're looking at color of the urine, what might be something that is in a UTI with cloudy, that bacteria or sediment, things like that. That's what we might see. It's not necessarily the amber. Frequency. What does frequency mean? Yeah, going often. A lot of times we're irritated, the bladder is irritated, and so any little bit of urine irritates that bladder even more. So people feel like they have to go a lot. Urgency? What is urgency?
I gotta go. I have to go.
Yeah, I gotta go right now. Like I really have to go.
I'm doing
Yeah. And then dysuria. What's dysuria? Painful, uncomfortable. It's kind of, actually, I'm not sure what the book calls it. I need to look at that. Anybody know what the book says? I don't remember what it actually says, dysuria as the definition. Painful urination. Okay. So yeah, any kind of pain, discomfort. So I apologize. I didn't let you choose more than one correct answer, but I feel like we actually learned a lot here, right? Because now we learned that ammonia smelling urine, that's not actually a sign and symptom of UTI, right? If you say foul smelling, that would be an indicator, foul smelling, but not ammonia. Was it a choice?
No, but.
Yeah, if you have blood in the urine, that could be a cause from the irritation. So signs and symptoms that people are going to have, just like we talked about, frequency, urgency, cloudy, foul smelling urine, hematuria, which is another name for blood in the urine, or pelvic pain. Pelvic pain is more from when you have the infection that's here in the bladder, that cystitis, that infection of the bladder wall. A lot of times we talk about different organs of our body. We feel them in different places. We're going to talk about our kidneys in a little bit. where do we usually feel kidney pain or kidney issues at? Yeah, on our flank, it usually radiates to the back. Our bladder, it usually is more of a pelvic pain, which is kind of like if you think about the urinary pelvis, that area, it's kind of like if you think of a hammock of where your bladder and kind of the bottom of your organs hang out. Usually that's where people will feel that pain. It's kind of a heaviness. We'll describe it as a heaviness or irritation there. With cystitis, it's that pressure. Pyelonephritis, it's costrovertebral tenderness. Costrovertebral. When you have a person so you have their rib cage. Oh goodness. This is not, okay. This is not anatomy and physiology, okay? This is just for our purposes. You have your vertebrae and your rib cage, and it's kind of this angle right here. So it's kind of like if you think about, feel for where your ribs are at. Yeah, and then kind of right below your ribs, between there, like one line over for ribs, one line kind of down. That's usually where you will feel, people will feel kidney pain. That's what's called the costrovertebral angle. I hope nobody actually looks at that in the future because they will have no idea what we're talking about. Or maybe they will, I don't know. Older adults, we talked about this a little bit. A lot of times they don't present with normal symptoms, where most of us in the room, we'd be like, gosh, it hurts when I pee, I feel heavy, I have to go all the time. They're just confused, right? Somebody comes into the emergency room, urgent care, maybe you're working at a long-term care and Mr. Smith, who you know real well, all of a sudden is really confused. First thing we're gonna do usually is check their urine, right? We're gonna see if they have a UTI that started, because older adults just present a little bit differently. Yeah, yeah. You want to tell them like a quick synopsis of that?
Yeah. They called my. Like, only got oxygen, so it's oxygen, the oxygen, but then when it's not there, it's fine. And at the end, I was like, oh, well, we got his catheter and his bag was like completely empty. And he was like super confused, he thought it was the 1900s. And then they took him to the hospital and then the next day he got.
Yeah, yeah. And so it can become systemic infection as well, right? So the localized infection is where you have just the irritation in the bladder, pain, or it could be bladder, urethra, kidneys. But once your body starts having a systemic reaction as well, you can have fever, chills. You can either eventually can have sepsis, which is a full, like an infection in the bloodstream in the body. It can be serious. Excuse me. So when we have patients and we're thinking, gosh, do they have a UTI or not? This is what we're going to look at and start asking. So we're going to look at things like that patient. Do they have a catheter? A urinary catheter predisposes somebody. Why does it predispose somebody to have infection? Right. Yeah. Normally we have little valves and things that keep everything closed up from the outside, but a germ could just hop on that catheter and walk its way up into the bladder, which is what they do. If you look under a microscope, some of those bacteria and think like how they move, it's so crazy. Like it's bizarre. It's really interesting. If they have had surgery recently, if they had to, especially like where you had to have a catheter placed for the surgery, we want to ask patients about their voiding pattern, right? Are you somebody who normally voids every couple hours and now you're in the bathroom every 10 minutes? Might be indicative of something going on. Want to ask them about some of these signs and symptoms that we already talked about. And we're also going to look at the urine. We're going to look at volume, how much, the color, the concentration. How do we tell concentration? Specific gravity. If you're just looking at it, sometimes you can just go by color too. If you're like, gosh, this is really dark amber, you know,
Blood, cloudiness, foul odor. We also want to look at a urinalysis if we have it, or we want to suggest, hey, we might want to order a urinalysis. So we're looking at nursing diagnoses. They might have acute pain, impaired urinary elimination, maybe some ineffective health maintenance behaviors. It's kind of a big term, but like we talked about wiping, maybe somebody doesn't know how to wipe correctly. That might be their issue, is that they don't know how to maintain healthy behaviors. And so we need to do some education. We want to make sure that we're giving antibiotics or antimicrobials as ordered. If we're going to get somebody, start them on antibiotics, what do we want to make sure, like what other intervention is done first? Get a culture first, right? Because if we give the antibiotics after, it's going to affect those results. We want to do pain control. So you might have a urinary analgesic. There's some medications that can actually help kind of numb that urinary, the urethra. And so it doesn't hurt as much as people are peeing. Sometimes heat, like warm packs to the belly, if there's cystitis or inflammation, infection of the belly, that can be helpful. We're also going to monitor their intake and output. So when we're teaching our patients with UTIs, we really want them to increase their fluids. A lot of times patients with UTIs will have some dehydration because it hurts to pee. They don't want to pee, and so they don't drink very much. They might also be running fevers, right? Somebody is sweating off fluid from a fever. They're not going to have as much fluid to pee out. So we really want them to increase the fluid, because we want to flush things out, especially if you have bacteria in your bladder. The antibiotics are going to be treating that, but we want to flush it out as much as we can. We don't want any of that hanging out in there. We also want to teach them, how do you recognize when you're starting to have a UTI? Because if we can recognize these things early and treat it early, it's much less likely, if it starts out as a urethral or bladder infection, to then develop into a kidney infection, right? We also want to talk about prevention. How do we prevent? Are we wiping correctly? Are we drinking enough fluid? Are we, some people are just more prone to bladder infections. We might then also recommend, hey, let's drink some more cranberry juice or some things to kind of change some of the pH of your urine. Let's do some things to help keep you healthy as possible. Okay, so now we're changing. Now we're not talking about urinary tract infections. Have I told you guys that's what I do for my husband? No? Okay. When my husband and I are talking and I change topics, we're talking about who's getting the kids to school. And then I'm like, okay, now we got to talk about going to see your parents next week. I'll go. And then I'll just keep talking. Because then he knows that we're talking about something different. It works. We've been married for like 22 years. But sometimes you just got to keep up. So if I double clap, that means we're moving to our next topic. So urinary tract obstructions. Or I guess I should say urological obstructions. So we're talking about urine is produced in the kidney, right? So anywhere along this tract where it either comes to the bladder or empties out of the bladder, that's an obstruction. It's always significant, meaning it's always a problem, right? It doesn't matter if it's just partially obstructing or fully obstructing, it's causing a problem. It could be unilaterally, meaning you might have something that's obstructing one kidney. It might be bilateral, where you have something obstructing both kidneys, or maybe something that's totally obstructing the urethra or the bladder. It talks about backwards pressure. So normally, we talk about our pressure system. All of our blood flow is coming through to our kidneys. It's filtering, right? That pressure is kind of coming here, moving the urine down into the bladder and going out. If you have something, let's just say here in your urethra, you have something in there. You've got bladder that's getting backed up. You've got your ureters that are getting backed up, and the kidneys are getting backed up. That's more pressure that's kind of building backwards. That's what I mean by backwards pressure. There's something blocking it and it can't get through, and it's causing this backwards pressure. It can be rapid or slow. It depends on what's causing it. And it can also distend the kidney and cause kidney damage itself. That distending the kidney, that's called hydronephrosis. And that's where this kidney here can actually get really swollen and big because there's so much fluid from that backward pressure that's building up in it.
Does that cause like the kidney tissue to die? Cause I'm just breaking down the word.
It can. Yeah.
Okay.
Yeah, it can cause damage. So when we talk about obstructions, we're going to start from the bottom to the top, kind of like we did with our infections. So there can be urethral strictures. So when somebody's peeing, there's a stricture that are not able to come out of the urethra very well. It can be from injury. Think about somebody who had to have a surgery on their urethra. Somebody who had a chronic catheterizations, different things can cause those strictures or damage. STDs or STIs can also cause some of those injuries. Cancers, also the most common one of all of these is probably an enlarged prostate. As men get older, oftentimes their prostate is enlarged, which is, we'll just say this is the prostate. It puts pressure on that urethra. So as it puts pressure, it kind of pushes in on the urethra. Now the urethra is just it's a flexible tube, right? Think about the Foley catheter, right? Imagine maybe that's just inside of somebody, that's the urethra. If you push in on that Foley catheter, it's gonna block off, right? So men with their prostates, when they're getting bigger, that prostate keeps pushing in on that flexible tube. It makes it very difficult to fully empty the bladder. A lot of times with these patients, you'll see them where they can only pee little bits at a time, like really when the bladder is usually full. And that's when they have enough pressure in the bladder to finally get some of that urine out of there. So signs and symptoms, frequent UTIs, right? Because we have urine that's just sitting in the bladder. It's more risk of just becoming infected when it's sitting in there. And then how do we treat it? Well, most of you guys now in clinicals have seen, hey, if we do a bladder scan and the amount is over 350, 500, whatever it is, then we put a catheter in and we drain it, right? That's a nice stopgap measure, meaning that treats it at this moment. But what we really want to do is look to see what is the bigger problem, because we don't want to just keep catheterizing somebody over and over again if there's a bigger problem at hand that we really need to solve or fix. A lot of times, patients will have urethral dilations. Sometimes with men, they'll have surgery on their prostate to remove part of it to kind of help that opening be more whole again. Oh, all right, this is a good question. Nephrolithiasis. Is that kidney stones or ureter stones? Just a little bit of word checking. Okay. All right, most of you guys got it. Kidney stones. Nephrolithiasis is kidney stones. I like to remember because nephro, that really means kidney. Anything with nephro is going to be kidney. What is the name for ureter stones? Yeah, erythrolysis. I think I'm saying that right. But it's that the ureter, in the ureter itself. So moving beyond, we talked about the blockage in the ureter. Now we're going to talk about blockage in the kidneys. So people can form these stones, or what we call them, and they can be formed for lots of different reasons. Some people are just genetically predispositioned to form these. Some other things can cause people to be more likely to get them: dehydration, a diet that's high in different things. But what they are these hard, small stones. And when I say small, they are tiny. Like they look like, not like even pebbles. It looks almost like tiny fine sand most of the time when we see them finally. If they're very large and need to be surgically removed, they can be quite a bit bigger. When you see the chart, when you're in clinical looking, a lot of times you'll see the word calculi. Sometimes they'll say renal calculi. That's just another word for stone. So if you see that, you're like, man, it said urolithiasis, but then also calculi. What is it going on? It's the same. So nephrolithiasis, that's kidney stones. Ureterolithiasis is ureter stones. So it might start in the kidney, and then those stones can break free and move down into the ureter.
So renal calculi probably is the one that you might be- Or is it just
Yes, yeah. And so that's one thing I want you guys to know, these stones are movable. Most of the times they do move through your system. I bet a lot of you guys have had a kidney stone without even realizing it. Your body just kind of moves it through, and it's tiny and you don't even feel it. And it will go from your kidney, all the waste products that our body is filtering out, and then it kind of will move through. A lot of times patients will say they can feel it as it's moving down. They're like, oh yeah, it was hurting so bad here, now it's here. And then they'll have this amazing feeling of where it's better because it moves to the bladder, and then they're able to pee it out usually. So here is a picture of where you have some stones up in the kidney. And so here, see where this urethral stone or ureteral stone. See how it's blocking everything here? See how this is backing up, getting bigger? There's all this fluid that's trying to push down and it can't. So that's where this backwards pressure is happening here to this kidney. This kidney is probably under quite a bit of distress because it can't empty out. Everything is getting backed up in here. You can see where this is bigger, the kidney's starting to get a little bit bigger. You can also have these calculi or stones. See how it's kind of got horns a little bit, I think about an elk or a deer, how they have the reindeer horns, and they actually can grow kind of into the kidney itself. Those are called staghorn calculi. Those are really difficult because they usually aren't able to pass, and they're really difficult to break up. A lot of times patients that have large staghorn calculi will actually have to have their kidney removed because it's causing so much damage to the kidney that eventually, if they can't surgically take it out or take out the stone itself, they have to remove the kidney. Big procedure, right? They have to really look over and make sure that's the only other option, but they can be pretty significant. Once they stone, it can move down into the bladder if it can. Sometimes they get stuck, and then it moves down to the bladder, and then can also become urethral stone. It's kind of interesting to see their track. Yeah.
so kidney stones?
Yep.
Wow.
There-
Okay, so in the kidney.
Yeah, and thank you for clarifying that. So the stones are just stones. We call them what they are based on where they are at, not where they're always formed in the kidney. So thanks for clarifying. So they're formed in the kidney, and then based on if they're in the kidney, in the ureter, in the bladder, that's what we call them. You just say, hey, they're. Does that make sense?
Yes.
Okay. So why does it happen, right? The pathophysiology. You guys are getting good at pathophysiology. So they say urinary salts, and they don't mean just sodium chloride salt. When they say urinary salts, it's all the extra kind of waste products that our kidneys are filtering. They kind of settle out in the kidneys, kind of if you shake a bottle of water with a bunch of stuff in it, it'll kind of fall to the bottom. That's kind of like in our kidneys. And sometimes all that extra stuff can kind of mold together into these little stones. If they're less than 5 millimeters, they're usually easily passed in the urine. That's pretty tiny. Larger stones can be pretty painful. They can get stuck or require some treatment. So why do people have them? Like I said, they're hereditary. Sometimes people just have a genetic predisposition to having them. If you're chronically dehydrated, you don't drink enough fluids, you're going to have more concentrated urine, more concentrated urinary salts which does make you more likely to form these stones. If you eat a diet that's high in sodium, protein, or sugar, that also makes you higher at risk. Men just happen to be a greater risk than women. I don't know why, other than that's just kind of how it is. So signs and symptoms. So the nephrolithiasis, and where is that stone at? In the kidney. They're mostly going to have pain in that costovertebral angle, like we talked about, and probably some urine blood or hematuria. Why would they have urine in the blood or blood in the urine? Trauma, yeah. What's the trauma from? Yeah, that stone is causing trauma in the kidney, and that blood is coming from the kidney to the bladder and on out. Urolithiasis or uterolithiasis, you can still have that flank pain, but it's not usually at that specific, like right up here in that costovertebral angle. It's usually a little bit lower and can be down in the pelvis as well. With this is where they usually have that intense urgency, like feeling like they need to void. Their body is saying, I need to get this out. I need to get it out, you know, and they can't, right? They can't move that stone along. They might still have hematuria. They can also have nausea and vomiting along with this as well. When you have bladder stones, you can also have hematuria. If that bladder stone, if it's settled down to the bottom of the bladder and it's blocking output, you might not see any urine at all. And you're going to have large bladder distension. That's a big problem. So how do we prevent, right? Some of the things that cause it, we reverse some of that. Make sure they're really well hydrated. We might tell them they might want to modify their diet. Also getting up and exercising. Really, if you're going to say, what's a preventative measure for anything? If you say exercise, it's probably going to be a preventative measure for whatever it is you're looking at. So diagnostic tests. If somebody comes into urgent care to the office, what kind of tests are we going to do? We're going to do some blood tests. We're going to look at a urinalysis. We want to get, and I couldn't figure this out. I meant to erase this, but the 2 24-hour urine collections, I looked that up. I couldn't figure out why it would be 2 24-hour urine collections. They might have 1 24-hour, but I don't think 2 is necessarily a standard that I've ever seen or could find. So just know if Davis asks you, it will say 2 24-hour urine tests. I think it would just be 1. They might get a CT scan. What would that show us?
Stones.
Yeah, it shows where they're at. Abdominal x-ray, that might as well. And then what's an IV pylogram?
Sounds like something with contrast.
Mm-hmm. Yeah. So it kind of tells us what it is. IV, it's given in the, like in your vein, and a pylogram, and that's where they induce contrast. They give it in your vein, your IV through your blood vessels. And then they watch that contrast go through your system. They can actually see it go through your kidney, and it can highlight if there's areas that are blocked from stones, it won't be able to empty out. And they're like, oh, we can see exactly where things are blocked at from that pylogram. So therapeutic interventions, if it's a small stone, right? 5 millimeters and less can just pass normally. If it's a little bit bigger than that, we might just want to say, hey, let's do a lot of hydration. If they're hospitalized, we might give them IV hydration as well, in addition to oral hydration. We want to give them some analgesics. Tamsulosin is one of the medications we can get that kind of helps relax those smooth muscles and open things up. Might help them to pass that stone.
What's it called?
Tamsulosin. If you have a large stone that people aren't able to pass on their own, so we're gonna do a few things. We're probably gonna do IV fluids for sure. We're gonna do a lot of pain control. We might do some diuretics, try to help somebody to push more fluid out that way. They might actually have what's called a lithotripsy as well. I think, oh yeah, this picture has it. I've never seen a lithotripsy that looks like this, but essentially you have somebody, it's a surgical procedure, and you break up the stone on like sound waves. It's really interesting. Like, you know, you've seen like sound waves that like shake things, right? Essentially, it's very concentrated, specific sound waves that can break up those stones. It kind of seems like magic a little bit. I don't know how it exactly works. I know it's very specific to that area. And you have to be trained. It's our providers, our doctors who would do it. But it can be very effective at breaking up those large stones. In addition to that type of surgery, they might do a cystoscopy. That's where they go in and they do like, so just like you guys would do a Foley catheter, it's like a little bit bigger of a Foley catheter and it has a camera inside of it. It also has like a surgical arm where like a little tiny arm where it can go in and try to break up the stone or introduce like other, anyway, it's really interesting, but and that can all go minimally invasive because, right, it's not minimally invasive, but it's not actually creating a surgical opening. It's just going through the urethra. So if you have a stone in your bladder, they will go in like they do, like if you're gonna catheterize somebody. And that little tube will go through the ureter and find where that stone is and try to break it up. Sometimes this percutaneous nephrolithotomy, sometimes if somebody we can't break up the stone and this kidney is getting bigger and bigger and it's starting to cause damage because there's so much pressure, we might put a tube in the kidney called a nephrostomy tube. And that's a way, it's an outlet for that urine to drain out of the kidney. I think I have a picture of that in just a little bit. But sometimes if they can't break up this stone from down low, sometimes they'll put in a nephrostomy tube and they'll go in from that tube itself and introduce instruments there from the top to try to break up the stone from that way as well. So some complications of these urinary calculi, urinary stones, right? So they can develop UTIs, especially if you think if the urine's getting backed up, anywhere where we have fluids or things that are just kind of in stasis, they're not moving around it as much. They're just a lot more higher risk of having like developing an infection. Hydroureter, and that's where the ureter gets kind of big and swollen like we saw. Hydronephrosis, that's where the kidney gets bigger and swollen. They can go into shock or even sepsis. It could also develop chronic kidney disease. So data collection. One thing that's really important is that we strain all of the urine. Why do we do that?
Stones.
Yeah, we want to check, we want to see if we can find them too. Has anybody strained urine before? No. It
Get a little thing like using a kitchen, a string.
yeah, well, kind of. Usually in most facilities, it's paper. Or it's a
paper funnel.
It's like a paper funnel. It's like kind of like this, but maybe cut off here. And you just put it on top of there, like you have them void in a hat or you collect it somehow. And then in your cylinder, you put your little strainer on your cylinder and then you just dump the urine in. And then after that, you kind of look, see, usually there's nothing. I've only seen it twice where I've actually seen the stones. They were really tiny and they looked like little, like they were hardly anything. But I was like, that's what you're causing all these problems. They really can be, it can be a lot. It can be very painful for people. But we do want to strain it all because first we want to know, have they passed it? Have they not? And they usually want to send them to the lab because they want to say, okay, now that we know this person has these stones, what's the cause? What are they made of? It might help us to know how to help that person prevent them later.
Yeah. So when people have kidney stones, because I've had one, and it makes me feel like I have to pee 24 hours a day. Like it's just that constant annoying little tingle, like you gotta pee. And then when you go, it's like,
Yeah.
Is that like common or?
Yeah, it's usually irritation of the renal urinary system. Everything's irritated. And so when it's irritated, it just feels like you have to go. Yeah, a lot of times, like patients who have Foley catheters in, a lot of times they get irritated in the urethra as well. And a lot of times patients with Foley's say, I just feel like I have to pee all the time. Or once it's taken out, they're like, I just feel like I have to pee all the time. And it's because that irritation that's there, that just causes that feeling like they need to go. All right, so if you're taking care of somebody that has renal calculi or renal stones, which actions? This is select all apply. I hope you can choose more. So, just choose one you think should be a priority action. All right. Okay, for the most part, pretty good. So we're not gonna limit fluids. We're actually gonna encourage fluids. We really want them to be hydrated. We're gonna strain all the urine. We don't want bed breaths. We actually want them up and moving as much as possible. That movement is actually gonna help promote that stone passing through where it's gonna go. So getting up and moving is really beneficial. Your patients who have a kidney stone aren't gonna wanna hear it, but you're gonna say, listen, I need you to hold on to that IV pole. I'm gonna tie up the back of your robe and I need you to do laps, because it will help move things through. Restrict dairy products, not right now. Afterwards, if we're like, hey, you're eating too much calcium, we did these things and we gotta restrict some of the calcium you take, but not for this. We want to provide pain relief and we're going to give some IV hydration. All right. Nursing care, strain urine, hydration, teaching. So hydronephrosis, and that's what I was talking about. When your urine gets backed up, it's in the kidney can't move it anywhere. So you got pressure, you can cause kidney damage. The big issue is you got to treat the causative agent. Whatever is causing that pressure to back up, that's what you want to treat. This is kind of a gnarly picture where you see kind of what a normal kidney, ureter, and bladder looks like. And you can see how it's starting to get backed up here. Look how giant and swollen these are. You can see how really painful this can be for our patients as this backward pressure is happening. So they're going to have the same problems: frequency, urgency, dysuria, flank and back pain. We want to treat the cause. If it's a urinary or like a ureteral blockage, we might just need to put a catheter in, right? I think a lot of times males with prostate issues, they have this happen because of their prostate. They can't empty, so the bladder gets enlarged and it just backs up from there. So they might just need a catheter until we can figure out how to help that prostate. They might need stents placed, right? Maybe there's some stenosis area up here in one of these ureters. And so if we put a stent in, that will help keep it open so we can drain down. They might have that nephrostomy tube, like I talked about. Of note here, when you do I&Os with a patient, you want to make sure you are documenting first, you want to always document the urine that comes from the nephrostomy, right? Would this patient still pee if they have a nephrostomy tube over here?
No.
Yes.
Yeah,
Yeah.
because this kidney over here is still making urine and it's coming down to the bladder, right? So if they have bilateral nephrostomy tubes, they might not pee. The nephrostomy tube actually might not collect all of the urine, so there might still be some that comes out.
I have residents that he has both, but
Uh-huh.
he still.
And he still has pees, yeah. So you want to make sure you're documenting an I&O very specifically. You want to document how much is on, if they have 2 nephrostomy tubes, what's on the right, what's on the left. We also want to separately document how much urine is coming out. Yeah, question? No question? Okay. So cancers of the bladder. So we're still talking about obstruction issues, right? So if somebody has cancer in their bladder, that can cause obstruction where urine can't flow. It usually is more common in men, usually ages 50 and older to 70. If you smoke, you are 2 times higher risk of bladder cancer. I thought it was interesting that the book talked about each cigarette increases your risk of bladder cancer. Also industrial pollution. If you work around a chemical plant or something like that, that's also a cause that could affect you to develop cancer. So bladder cancer is one of those sneaky cancers that a lot of times people don't know about until it's well developed, because the early symptoms, there's not really any. They might have a little bit of blood in their urine, but that can easily be misdiagnosed as, maybe some urethritis or something else that's going on that causes a little bit of blood. Usually it's when that cancer is larger and actually causing obstruction or something quite significant that people are actually diagnosed. A lot of times their symptoms they have are that pelvic pain, lower back pain, difficulty voiding. So they're usually going to do a cystoscopy to diagnose. That scope, like I talked about, like a catheter they introduce to the bladder. Again, it's got a little camera, it's got a little arm, and it can take little samples and send those to pathology to see kind of what kind of cancer, what is this? Is it cancer? They might do your urine or somebody's urine for tumor markers as well. That's another less invasive way that could help diagnose. They also want to do imaging, meaning x-rays, CT scans, things like that. That'll help them to see what's going on. So interventions, chemotherapy, immunotherapy, photodynamic therapy. That's where you have like concentrated light rays that I believe it's like a medicine you give, and that medication attaches to certain things, and then it makes that tissue very sensitive to light. And so that's one way you can combat some tissues or fast growing tissues. They might do this fulguration is just like removal. So they might go in and take out some of that. They might do a cystectomy to remove part of the bladder, or a urinary diversion. They might have to remove all of the bladder. So incontinent urinary diversions, there's a couple different types. So if you have a cancer in your bladder is usually the most common reason why you would have to have a urinary diversion, meaning something happens between here and here where you can't pee like you normally would. So somebody has bladder cancer, we got to take out the bladder, remove it. There's something where they can't pee normally. So we're going to divert this. So how do we divert it? So urostomy or ileoconduit, your ileum is part of your bowel, and they use part of that bowel to make a little pouch. Then they kind of attach your ureters into that ileum, to that little pouch, so that drains into that pouch. That pouch becomes your new bladder. And then it's made into like an ostomy, like if you have a colostomy or an ileostomy, like with bowel, it's very similar to that, except for it's urine. So it's just draining urine out that way. That's what's called an incontinent urinary diversion. What that means is that as urine comes from the ureters into that new little pouch that we formed, it's inside, right? Inside your body, little pouch. It just empties out into that little bag that we've made, right? Incontinent, they can't control it at all. Continent urinary diversion, it's less common today. Usually people do that ileoconduit like we talked about. But they can actually, I think I've got a picture of it. Here we go. It's where they put it essentially into, they make another pouch into this new bladder, and then the new bladder down out. There's a lot of things that have to go into that, like where you have to have like your urethra that's still functional and some other things. It's not super common for this to happen, but you might see somebody who has an implanted neobladder is what it's called. Yeah. So nursing care, we really have to teach these patients, how do you take care, just like you guys learned how to take care of ostomies, right? For stool, we have to teach our patients how to take care of these ostomies for urine, because they're going to be filling up all the time. That's going to be how they pee. Body image is a big thing with these guys, just like with the colostomy and ileostomy patients have body image issues. Our patients with these will have them as well. We want to make sure we're checking skin, we're protecting the skin. Moving to cancer of the kidney. It's still a fairly common cancer, top 10. It's more common as you get older, over the age of 50. Men, again, like the bladder cancer, are going to have a increased incidence than women. Smoking, obesity, hypertension, long-term dialysis, or exposure to other pollutants are going to be some things that kind of increase your risk factors. So oftentimes, just like the bladder cancer, you're not going to have early symptoms. It's going to be the later symptoms. And it's going to be similar to where you have the renal calculi, where there's going to be urine, there's going to be blood in the urine, flank pain. They might notice a mass in the kidney area. If it's very large, like an outward, you might feel a mass. That's usually if it's a very thin person. But that would be pretty late stages of that cancer. It's often diagnosed after it's metastasized. What is metastasized?
Spread all over. everything.
Yeah, it's usually spread to somewhere else. A lot of times that else, the other place that it has spread to, that's what they've noticed the signs and symptoms of. And then they are like, oh, it actually started here in the kidney. Very similar diagnosing to what we would do for kidney stones. Except for they might do also biopsies, renal biopsies. And that's where you would just go in with a very small, long needle. They usually do it CT guided, where you would have a CT scan and they guide in to get just the right spot. They usually, when they do those, will have a pathologist present who can make sure you have the right tissue, right? They won't be able to say, oh, this is cancer or not cancer or whatever it is, but they'll say, yes, this isn't normal kidney tissue. We got the right spot. They might have to have surgery, radiation, chemotherapy. We want to look at monitoring their urine output. They're also after a nephrectomy, that's the total kidney removal, you're at a higher risk of having a pneumothorax. Just because of that, think of the yeah, essentially, yeah. Just they're kind of allowing things in. They might not close things up all the way. They might create an accidental opening. Oh, how about this? They're taking care of Mrs. McDuffie. She's 45 years old and she had a right nephrectomy, so took out her kidney. You note absent breath sounds on the surgical side. What do you do?
Take by the side, contact the surgeon. Calling,
Check for neurothorax, call 911. Right. So I would guess we'd probably be in a hospital. So we'd probably like call for help, is what I'm kind of hearing you guys say. So yes, notify the healthcare provider, rapid response team. She might have a pneumothorax, right? And so we want you to research immediate care. You guys look like you're about done. Let's skip over the S bar. Okay, renal trauma. So this is where you have, like, have you heard somebody talk about like a kidney shot? Like you're like in a fight and they got punched in the kidney or something? That's renal trauma. Or maybe a car accident, you fell. It's anywhere because our upper organs, like our heart and our lungs, a lot of other things, they're protected by our ribs. Our kidneys really aren't, right? And so if we fall or get punched or hit, that organ is getting some pretty direct pain trauma. And so it's what we're going to see is usually pain. We might see blood in the urine, just like with some of our other issues. You might even have bruising, significant bruising from the bleeding from the kidney around that site. Again, it's the same type of diagnostic test we're going to do for anything with the kidney, where we're going to CT scan, pylogram, we might get an MRI, and we want to treat whatever injury happened. If there's something that's sticking into the kidney, we might want to actually remove it, probably surgically, right? But we want to monitor their vital signs, I&O, pain management. Okay, it's break time. You guys made it. We did great. First session of MedSurg 2. How about let's come back at 9:30.
okay.
Yeah. Give me 1 second just to pause the video. Unless you want to be on video. Okay, thank you. Okay, I'm recording. Okay, there we go. So a fistula and a graft. I have pictures that I'll show you about these in just a minute. Here's a picture of a patient who might be on dialysis. Anybody ever seen somebody on dialysis before?
Yeah.
Yeah.
I got a question about that.
Mhm.
My mom was, my mother-in-law was on dialysis, and why, I'm not understanding, why does it make them so tired?
I mean, ultimately, I like to think about it like as if I had all my blood pulled from my body and washed and then put back in. Like, it's just such an artificial thing. Usually they end up coming back from dialysis being, what's that?
It's great.
Yeah. It's, you know, they end up being so tired and they're almost always cold, coming back from dialysis. It's just a really exhausting thing. But you can see where they have these two different bloodlines. And you guys know blood is not blue inside the body and red outside the body and all that. It just shows like, so
It's green.
it's green, yeah. So you have blood that's going out, it's getting cleaned, then filtered, and then it's being returned back into the body. Nurses run dialysis, you know, they run it off of doctor's orders. You know, but you have to be specially trained to do it because it's very intense, right? Like if you ignore your patient for a little bit and something's wrong, and you've got a lot of their blood outside of their system, not very good things. Here's what might look like in real life with a person on hemodialysis. I like that it does show here too, right? She's hooked up to a blood pressure monitor. They're going to be monitoring these patients pretty frequently during this to make sure that they're stable. So let's go back. So here, there's two different types of long-term accesses. This first one is a fistula, and that's where you use the body's own vein and artery, and you kind of stitch it together. Because when you think about when you're going into access, you have to have blood that's coming and going at the same time. That's where your access, that's where everything is happening. So they kind of stitch together an artery and a vein. Before somebody can do this, they have to do some tests to make sure they have good blood flow, that they're a proper candidate for it. B is a graft, and that's where they put an artificial vein or artery or just artificial blood vessel. And they kind of tie it in, one end to an artery and one end to a vein. Usually they both take a little bit of time to mature, but the fistulas, they usually take longer to mature because it's the actual blood vessels that are kind of growing together and like getting stronger. Together, do you have a question, Sharita? You know, I'm not sure because I've seen patients with both, and I don't know if it's just, you know, the type of like their blood flow or yeah, I've seen both of them. I'm not really sure why they choose each. If you have somebody going to, that's going to be having one of these, so if you have a patient who's on dialysis, like they're going to get a chronic access placed, we want to always make sure we're doing neurovascular checks, especially if you think about how, you know, we're disrupting this blood flow, right? So we really want to make sure they're getting good blood flow past this point, that it's not all being diverted back up the arm. We're going to check the capillary refill. We're going to check the sensation, all of those things. When you have a dialysis access, there's two things we check. We check for a bruit and we check for a thrill. Which one do you feel for? Yeah, so you feel for the thrill. So do you guys remember when we're listening to the jugular veins or the jugular arteries, we hear the bruit? You hear a bruit, which is like a turbulent blood flow, and that's what you'll hear on your dialysis access lines. Now, we showed dialysis access here because that's really common. They always start away from the body as far as possible, periphery. And then if something happens in this line, a lot of times it won't be able to be used anymore. It's too damaged, it's been accessed too long, too many years, and then they'll move up the arm, farther up and farther up. They'll keep creating new accesses, and then they'll go to the other. So sometimes you'll see patients with dialysis, many dialysis accesses, and you have to say, okay, which one are we using? But that's part of our assessment with somebody who has a long-term dialysis access. You always listen for the bruit and you feel for the thrill. You guys know what the thrill feels like? Is that the pulse? It's not a pulse. It's like this, like, yeah, if that was a feeling. But it's just like this little, like, you just feel the blood, like kind of whooshing
Like a
through.
brush.
Like a, yeah.
Like
It's
what?
real.
Why is the fistula getting big?
Oh, good question.
Yeah, I have,
Yeah,
my
I was
cousin
gonna
is on
ask you the same
dialysis.
thing.
like,
So the
it's
question
like-
is, why is it getting bigger? And that's because we're anastomosing or tying the blood vessels together, either themselves or with the graft, we are increasing the blood flow there. So we're actually growing those blood vessels. We actually want to grow those blood vessels because we want them to be bigger so that they help support the dialysis, right? Dialysis is if you have a small line, it's pretty slower on the rate. They can't do it as well or as efficiently. So if you have bigger blood vessels, you can do dialysis more efficiently, more quickly. So a lot of times after a fistula graft is placed, especially fistula, they'll give them one of those hand squeezers. And they'll just say, keep doing this, because as you keep doing that, more blood vessels, or the more blood that's gonna come down there, it's gonna help grow those blood vessels as well. So peritoneal dialysis. Okay, get out of here for a second. I feel like peritoneal dialysis is really interesting. So this picture, I don't know how to get it bigger, but see how this person is sitting down? With peritoneal dialysis, you're not always hooked up to something. So that's why people like this. Not everybody's a candidate for peritoneal dialysis, but if you are, you're able to do it at home. You're able to be a lot more independent. You don't have to those highs and lows. Like usually people on hemodialysis, they usually dialyze 3 times a week. So a lot of times when you get a report on somebody with hemodialysis, they're like, oh, they're a Monday, Wednesday, Friday person, or they're a Tuesday, Thursday, Saturday person. And then you have these wild swings of they're either like really tired from dialysis or they're doing okay. It's a pretty drastic way. Peritoneal dialysis, usually you do throughout the day or throughout the night, every day. And that helps to it mimics more closely what the kidney does as far as filtering and pulling out waste products. So you have, your peritoneal area here, right? You have a peritoneal cavity, which is really like a potential space. So if everybody took your finger and you poked through your belly button, you could separate your abdominal wall from your peritoneal, like your organs, and you could open up a space, right? We don't have that space open right now. It's a potential space, meaning you could make that happen. So what they do for a peritoneal dialysis catheter, so to put it in surgery or special procedure lab, they open up, make a little hole, and they put a catheter that goes from the outside into that space there. So kind of between the sac that contains your organs and the abdominal wall. Then what happens is through that catheter, they instill a bag of liquid. So kind of what this looks like, you would hook up a big bag of fluid and it would go into your belly. And it can be anywhere from 1 liter, 2 liter, 2.5 liters. It can be a lot sometimes. And it's a special dialysate fluid that is usually pretty hypertonic. When we talk about tonicity, why would we want it to be hypertonic? Yeah, so it will pull out fluid and other things from our body's peritoneal area. It's such a big space, a potential space in there. It interfaces with all that area and it starts to pull extra fluid, extra potassium, all of those things from our system. How do you think these people feel when they have that in there? Yeah, because what happens is they don't just sit like that and they're done. You fill it in and then you have your dwell time. And then people unhook and they just go about their day.
They go to the bathroom.
Hmm?
And then they just use the bathroom if they wanted to pee.
Nope, so it's not about peeing. It all is through that catheter. It's just sitting in their abdomen. So here, let me show you this little animation.
Either at home or at work. This type of therapy uses peritoneum as a natural filter. It has similar attributes to the artificial filter used in hemodialysis. Its pores allow the passage of certain substances while retaining others. A sterile dialysis solution is introduced at regular intervals into the abdominal cavity through a permanent catheter. This solution absorbs waste products such as urea and creatine from the blood and removes excess water. After a time, this fluid is drained and replaced by fresh solution.
So people will walk around with that fluid in their belly, right? And then after a certain amount of time, they will, it's usually a bag that has like a three-way stopcock on it, and they'll empty out the bag with all the stuff that's been sitting in there. And then they fill back up with the new bag, waiting to the fresh dialysate to pull out, and then they'll unhook and keep going. Some people do this multiple times, like 3-4 times a day. Other people will just do it during the nighttime. They'll do kind of this long, continuous one through the nighttime. But for a lot of people, it's a very good alternative to hemodialysis, where they don't have those huge highs and lows, the swings of their fluid and electrolyte balances, and they're not tied to being in a diet. Usually people's dialysis appointments, I mean, that's usually most of the day for them. That takes up, that's kind of your life is dialysis a lot of the time. Ooh, hold on. Let's go back to urinary renal. I used to have to do this as a baby nurse. That was 20 years ago. Now they have dialysis nurses who, like, I didn't do the diet like hemodialysis, but that was part of my responsibility as a baby nurse to do the peritoneal dialysis in addition to everything else. And I remember being like, shouldn't I be trained to do this? Anyway, I needed to do it. But it was really interesting because if somebody would start to have, like, they thought there maybe was an infection of the peritoneal cavity. And we would know because we would say, oh, it looks like the fluid that's coming out is getting a little bit cloudy. Like, I don't like how that's looking. They're starting to maybe have a little bit of a fever. We would notify the doctor. And on the next one that we would infuse in, we would put antibiotics into that fluid. So then the antibiotics would be directly to that peritoneal area. Sometimes patients would have like little like clumps and fibrin that would start forming. And so we would put heparin in the bags, and that heparin would help to keep those clumps and fibers from forming. Now, most of the time, if you have anybody inpatient that has peritoneal dialysis, there's like dialysis nurses that do it. But it was interesting. Oh, fun fact too. Eyes and nose. How do we do eyes and nose with peritoneal dialysis? Right? If it was 2.5 liters or 2 liters that we put in, well, at the end, or the beginning is usually the drain, right? So you drain them out, and then you flow it in, and then you take that bag you drained out and you go weigh it. And usually, if they're a 2-liter bag person that goes in, you'd weigh it, it'd be like 2650 or something. And you're like, oh, okay. We pulled off 650 mils of fluid excess out of there. So it's really pretty effective at working. Okay, let's keep rocking. So there's peritoneal. So kidney transplant. So you can have living donors or cadaver donors. Because we have 2 kidneys, you can function on one. And there are people that have offered to give their kidneys to other people, especially if you have people that have kidney disease or other issues in your family. Because just like we talked about blood products and having to be a proper match for blood transfusions, you have to be a proper match for any solid organ transplant as well. And so sometimes people will donate organs like kidneys to their family. If you have a transplant, you are then on lifelong anti-rejection drugs, right? Because you have something in your body that's not natural. It's not your own. And to keep your body from identifying it and attacking it, you take medication that kind of suppresses your immune system to say, oh no, it's okay. It's okay. It's like calming your immune system down. So when you have a kidney transplant, a lot of times your damaged kidneys, they kind of get they don't look like beans, but sometimes they do get kind of little. And you usually put your transplant, you keep the original kidneys in, and you just put the new kidney usually a little bit below. And keep it in there. Yeah.
Why don't they remove the diseased kidney?
It's not necessary. The diseased kidney isn't actually harming anything. By removing the diseased kidney, and we say diseased kidney, it's just non-functional, right? It's not like it's a source of infection that's sitting there to cause problems. It's just not working. By going in and removing it, you're risking causing more problems.
I'm like, he's walking around with 3 kidneys.
Mm-hmm.
Where's the space?
Oh, well, the diseased kidneys usually are pretty small. Yeah. So some of the nursing diagnosis, nursing care, really, we're gonna, a lot with fluid volume and electrolyte imbalances, right? That's what we're gonna focus on. We wanted with our impaired function, we want to really protect from infection. These patients have a higher risk of infection, a lot of them because of being diabetics, but also with a lot of their fluid and electrolyte imbalances, it just makes them more predisposed to having infection. I don't really want to do this case study because we're going to take up more time. Okay, end of that. Man, you guys, I always run out of time. I have so much stuff to do. Yeah, go ahead.
So, like, cadaver, filter, like, the person's already dead,
Oh, yeah.
or, like,
So with
person-
solid organ transplantation, and when I say solid organ transplantation, you can donate organs like your skin or your retinas, things like that. And somebody can be dead with those. For a solid organ transplant, like your kidney, heart and lungs, yeah. They do, it's a complicated process, but it's where somebody is usually brain dead. And then there's a process where if somebody wants to donate their organs, and that's just so you guys know, you will never have to ask that question to family if they want to donate organs. That is 100% always done by the organ donation people. So please know, like, it is never our place as a nurse taking care of somebody to ask about organ donation. The reason being that it could be very tricky for families if they're saying, wait, you're taking care of my loved one, but you also want their organs? Like, what does that even mean, right? It seems like a conflict of interest. So in the United States, at least, I've worked in multiple states as a nurse. You are always out of that equation if there's a potential for somebody to be a donor, and it's usually they're in ICU, right? Because they're usually on a ventilator, they're non-responding. They've done all these tests to show that there is usually brain death, but their organ, they're keeping functional with the ventilator. Then you would have, like here we have, oh, I can't remember. There's different companies. Thank you. Life Center Northwest is a big one. And they would come in and talk to the family about that. It wouldn't be anything that as nurses we initiate. But yeah, and it is, if you ever get a chance to see an organ harvest, it's very interesting. The people that do it, at least in this area, they donate their time, the surgeons, the operating room nurses, the techs. It's a very honoring thing. It's not something people go just for fun, but they realize the gravity of what's happening. It's a big deal. My mom, actually, that's why I got into nursing. When I was 11, she had liver cancer and ended up getting a cadaver donor. She had a liver donated and she had a transplant. And so I remember being just amazed that my mom she was younger than I am now. She was in her 30s and just came down with this random cancer. And I remember being so thankful that somebody chose, we found out later it was a 11-year-old boy who had passed away. But his family had said, they wanted to donate his organs. And my mom was one of the many people that then got to live her life because of this family's choice. And so if you ever get an opportunity or if you ever see or hear of it, it's a very sacred time. Like it's very interesting. Sorry, you have a question?
Yeah, so I saw that you posted for our individual projects, when will we get our?
Oh, yes, I will give those to you today.
Okay.
Yes. Okay, so I had a couple of things I really wanted you guys to do, and I'm so sad. So I'm just gonna give them to you to do at home on your own time for fun. So I was really excited, you guys. I saw Starbucks and they had this game with dice to learn how to do orders. And so I had this whole thing made up with medications. So we're not gonna do it in class, but if you want practice with medications, some of the ones we talked about today, like some of the antibiotics or furosemide, all it is there's a medication class, like thiazide diuretics. You just say action, what does it do? And then an example medication. And then nursing care, like what is something I need to know about this? Which actually, yeah. So furosemide, we talked about that one a bit today in class. What is its mechanism of action? It's a diuretic, yeah. It pulls fluid and electrolytes from the system. What is an example medication of furosemide? Furosemides, yeah, Lasix. Which actually, I think I should have put loop diuretic on here. Oh, well. What's in nursing intervention or some nursing care we need with that one?
Make sure your patient drinks water when they take water.
I know, daily weight, we're missing a big one though. Potassium levels. With somebody on potassium wasting diuretics, you always want to make sure you know what their potassium is or that we're giving a replacement if we don't need. Okay, the other thing is that a worksheet that just talks about laboratory values with renal disease. So it's kind of just one that helps you to think through, okay, with my vitamin D and calcium, is that going to go up or down in renal failure? Down. And then also
Calcium, what did you repeat that again?
calcium and vitamin D,
Down.
they go down. Yeah. So it's just kind of this worksheet to just fill out of, what do my lab values do with renal failure? So I'm just gonna set these two on the back sheet, on the back table. If you want to, you don't have to. I'll also post them online so you guys can see them as well. It's just extra information for you. What's in the last couple minutes of class filling out? So, what are your takeaways from today? Yes, once you have done your KWL, just submit that, you are done. I will post later your topics for the discussion board for the individual project. Remember, no class next week, but please watch the video online. Oh, okay, thank you.
For the individual project.
Yeah. Mhm.
I'll turn it in.
Yes, that's what, they were just asking me. I thought there was a place to do it, so I need to look to see where to put that at.
So that would be different from the.
I think so. I thought there was a way I could do it on the discussion board, but I think it might be, I might have to make like a different assignment for it. So, yeah, thank you for asking, though. I appreciate it.
She wants to write.
I will. Thank you. Have a good class or next class.
Yeah. I have two umbrellas.
Why, you don't do Yes, you got it.
Yeah.
So I work at night, like I worked last night. So if you see me randomly standing, it's so I don't fall asleep.
Totally fine. You do whatever you need to do to get through the day.
I'll just put it. Are we on? Yeah, we're still here. We're here. What are we on? There's never left.
Yeah.
That right here. Those pictures. Yeah.
Wait, are you sure I'm driving?
Yeah.
The one who you're terrified.
Yeah, but I don't wanna lose my parking spot.
Oh, your life is worth your parking spot. I get it. Okay.
Listen, you. Maybe, I don't know.
That sounds not fun either.
Never ending. Yeah.
I don't, I know better.